Hello, welcome to our today's session. Our today's webinar is on workshop on post-exposure prophylaxis and clinical scenario discussed of hepatitis B, C and HIV and presented by IMA Medical Students Network in collaboration with Hospital Infection Society India, Aligarh chapter and Student Network Organization. And for this CME, our digital partner is Clarnet. Now I'm playing the Clarnet video. Please have a look. Now, I am just handing over the session to you, Dr. Shruti ma'am. Please start. Dr. Shruti ma'am.
Good evening to one and all. I'd like to introduce the moderator. I am Shruti Gupta, Indian Medical Association, IMA-MSN editor, and Amrita National Medical Coordinator, IMA-MSN, National Designing Coordinator, SNO-India.
We welcome you for today's session. Thanks for gracing our event with your august presence. I now proudly announce our organizers, that is Lakhan Prakash Gupta, State Convener, IMA-MSN UP, and National Vice President for SNO-India. Also Sakshi Singh, State Secretary, IMA-MSN UP, and North Zone Coordinator, SNO-India. I especially welcome Dr. Ekta ma'am, Head of Department of Clinical Virology, Dr. Harris sir, who holds position of Vice President and Chapter of IAMMM, and Dr. Fatima ma'am, Associate Professor in the Department of Microbiology. Thanks for taking out our time and inaugurating the event with your presence. We thank IMA-MSN and SNO-India for organizing such events and providing medical students a genuine platform to interact with each other. Now I request Shruti to brief us about IMA-MSN.
Indian Medical Association is the only representative voluntary organization of doctors of modern scientific system of medicine, which looks after the interest of doctors as well as the well-being of the community in large, and helps for the promotion and advancement of all the medical students widely. IMA-MSN, Indian Medical Association Medical Student Network, is the students' wing of IMA, which aims to connect medical students from all over the medical colleges in India with the same goal and purpose of IMA, that is Indian Medical Association, while also provides means for co-curricular activities for the advancement and for the all-round development. HISI, Hospital Infection Society India, it is an association which deals with prevention and control in improving care, sanitation, and take care of fundamental health facilities. Mission: society's mission is to provide the necessary tools, information, and technical resources to its members and partners to develop infection control programs in their institutions focusing on evidence-based medicine. Now, I would like to request Amrita to explain about SNO-India.
It is an independent organizing body within the network, TUFH, in official relationship with WHO. We aim to provide the participation of medical students in the process of constructing a robust healthcare system for the next generation. We work towards designing spaces for interdisciplinary collaboration to bring together students with varying interests and areas of expertise in the forms of a friendly and supportive environment. We also establish opportunities for our members and associates to interact with and assimilate knowledge from experts, professors, public health professionals, and peers to further the goal of gaining a holistic view of the healthcare system. As an organization, SNO-India is not just well-structured, but also well-motivated with a razor-sharp focus on its goals ahead. Through this year, we intend to actively move towards better collaboration, improved inter- and inter-organizational relations, several competitive and non-competitive events across various medical and non-medical spheres to kindle the interests of the entire medical student fraternity, and of course, the overreaching objective of establishing a better healthcare system in the country through handcrafted awareness campaigns. I would like Shruti to talk about the HISI now.
As I told, HISI, Hospital Inspection Society, India, it is an association which deals with the prevention and control and to improve care, sanitation, and take care of fundamental health facilities. Their mission is to provide the necessary tools, information, and technical resources to its members and partners for the whole round development. Now I would like to highlight some data of hepatitis. WHO estimates 296 million people are living with chronic hepatitis B infection in 2019, with 1.5 million new infections each year. Some regional level studies, it is estimated approximately 40 million people who are chronically infected with hepatitis B and 6 to 12 million with hepatitis C. Now I'd like to call Professor Haris, and I'd like to speak few lines for him. सामने हो मंजिल तो रास्ते न मोड़ना, सामने हो मंजिल तो रास्ते न मोड़ना, जो भी हो मन में वो सपना न तोड़ना, सामने हो मंजिल तो रास्ते न मोड़ना, जो भी हो मन में वो सपना न तोड़ना, कदम कदम पे मिलेगी मुश्किलें आपको, कदम कदम पे मिलेगी मुश्किलें आपको, बस सितारे चुनने के लिए, बस सितारे चुनने के लिए कभी ज़मीं मत छोड़ना, बस सितारे चुनने के लिए कभी ज़मीं मत छोड़ना. I would like to highlight the major points about sir. Professor Haris M. Khan sir is head of Microbiology Department in Aligarh Muslim University. Sir is also president at HISI, and sir has flawless command over parasitology, nanomicrobiology, immunology, bacteriology, and hospital management. Sir is not less than a boon for our medical society as well as for virology department. He is medical in JNMC College. Now I would like to welcome this eminent personality to share his tremendous experience in field of medical science. Please welcome Professor Haris M. Khan.
Thank you so much for the nice introduction. Dr. Ekta, Dr. Fatima, organizers, participants, good evening, everyone. Today's the topic is very relevant to the day-and-day experience which we have in our hospital, or not only in our hospital, all over the world. The post-exposure prophylaxis about which this discussion will take place today is a very important topic, which most of the time we have got people have got different views about how to manage this particular problem of post-exposure prophylaxis. Now, this post-exposure prophylaxis is a common problem in all health setups, and it involves everyone, right from the consultants to the residents to the nurses and the MTS staff. Whenever there is a exposure, there is always a panic, and that panic results in sometimes in a wrong management of these particular cases. So it is very important that a very clear-cut guidelines should be told to everyone. What is the standard guidelines which is accepted by all? And I would be looking forward to especially the importance of immunoglobulins in hepatitis B as a post-exposure prophylaxis. Because I think Dr. Ekta has got a lot of experience in this particular field. She will be able to tell us actually what is the role of the immunoglobulins being used for post-exposure prophylaxis against hepatitis B. Because the first demand from any healthcare worker is that they should be given immunoglobulins. And that immunoglobulins, according to my whatever limited experience I've got, has got its own problems. So whatever is the standard guidelines, we are supposed to be following that. And that is where we should try to, once after the discussion, we should try to tell each and every healthcare worker that this is the guidelines and this is what we are going to do. Especially the ones who are dealing in the first line. For example, the emergency medical officers. They are the first ones who deal with these such cases. They should know what to do. Because what happens is that once you give a prescription, for example, if somebody has got pricked with hepatitis B, and anybody may be a resident or maybe a consultant, he writes immunoglobulin, and that is where the trouble starts. So I think it is a very important subject which is going to be dealt with today. And good speakers, Dr. Ekta is there, Dr. Fatima is looking after this problem in our hospital. So thank you so much for inviting me, and I'm looking forward to this discussion. Thank you so much.
Thank you so much, sir, for gracing this evening with your precious words. I'm very thankful to you for coming over here and speaking about this current topic. Thank you.
Thank you. Thank you so much.
I'd like to request Amrita to please take the session forward.
Amrita, please unmute yourself.
Sorry. Thank you so much, Shruti. I would now call for the polling, ma'am, with your permission. Fatima, ma'am?
Please do. Please start with the polling.
Yes, so everybody is requested to fill in the form for polling. It will be available. You're requested to answer the questions.
The Clarnet team is
Hello,
supposed to
ma'am.
And I would.
Can we launch the poll?
Yes, please.
Yes.
The participants, please be aware of the fact that this polling is actually the pre-assessment.
Please, all the participants are requested to fill in the forms.
The certificates will be generated for those who fill the pre-assessment and the post-assessment. This is sufficient time for the poll to be answered. The Clearnet team can decide if the participants have answered the poll and they can display the results.
Okay, okay, ma'am, sure, sure. Ma'am, can I end the poll?
Can you assess that how many participants have responded so far?
64, ma'am.
Yes, I think that is sufficient. You can end the poll and display the results.
Okay, ma'am, sure.
Okay. Can we save these results?
Ma'am, is there any option to save?
Okay.
Can we stop? Can I stop the sharing, ma'am?
I think this is fine with us.
Okay, okay, ma'am.
Amrita, shall we start the next session?
Yes, ma'am. So now I would like to call upon Dr. Ekta ma'am to speak. Ma'am has been the head of the Department of Clinical Virology. She's also the nodal officer WHOCC for viral hepatitis. She's the nodal officer for COVID diagnostic and genome sequencing. Ma'am has more than 22 years of experience in clinical diagnostic virology. She has more than 100 scientific publications in induced national and international journals, and she has been the author of 9 chapters in books. She has to her credit several extramural and research grants, both at national and international level in clinical virology. Started 2 unique courses at HBS in clinical virology, PDCC in Hello.
Good evening, ma'am. Welcome
good
once again.
Yeah, thank you, Fatima. Shall I start the session?
हाँ जी ma'am जी.
Okay. So thank you, Dr. Fatima and Professor Harris Khan and the society for inviting me and speaking about me. And this is a very apt topic, and I could see with the responses that yes, the education activity needs to be upgraded. Quite a lot of you know about it, but still we must speak about this needle stick injury and post-exposure prophylaxis, especially regarding to hepatitis B and C. I'll share my screen now. Can you all see my slides? Are my slides visible?
जी ma'am जी.
Okay. And
Yes,
I'm audible also?
Ma'am.
Okay. So,
Yes,
good evening, everyone. The topic which has been given to me today to speak upon is the needle stick injury and post-exposure prophylaxis, especially for hepatitis B and hepatitis C virus. I bring greetings to you from the Institute of Liver and Biliary Sciences. So what is a needle stick injury? Now, a needle stick injury is if we all know, is a percutaneous injury where there is a penetration of skin and mucous membrane by a needle or any sharp object, which is in contact with blood, tissue, or any other body fluid before the exposure. So when there is a penetration of skin mucous membrane through a sharp object, and that sharp object is contaminated with blood, body fluid, and infectious fluid, then we only call it as a needle stick injury, right? So, how are these needle stick injuries and healthcare workers associated? As we have been, Professor Khan has also said that these are healthcare workers at highest risk of exposure to these bloodborne pathogens. Hepatitis B, C, and HIV are the 3 most common bloodborne viruses which are mostly associated with these needle stick injury. There are about 3 million NSI in healthcare workers and 37% by hepatitis B, 39% C. And so just see that proportion of needle stick injury by HIV is so less as compared to B and C. They're quite more. The risk of transmission is directly related to whatever work and where we are positioned, what kind of work we are doing, especially like the surgeons who are in contest, who are doing all these surgical maneuvers, emergency doctors, the lab professionals who are handling the blood and infectious fluids, they have been identified as the persons with the highest risk of exposure. Now, how are healthcare workers and bloodborne viruses interrelated? So these are patients who have got these infections and we are the healthcare workers. So we are also, patients can transmit the infections to us through these unsafe injection practices and needle stick injury. And we also can transmit So the turning the table means if we are infected, then we can also transmit to the patients. So it is a cycle, like you have these viruses and the patients can be transmitted when an exposed healthcare worker. A healthcare worker can also be infected and can transmit to an immunosuppressed or a susceptible. So it is like not only one side, it is also the turning the table around. Now, the risk of transmission depends upon, I think most of you have answered it well. So hepatitis B has the largest, chunk of the transmission, the risk of transmission, the risk with the hepatitis B virus is highest. So we normally, to remember, it is like 1:3 by B, 1:30 by C, and 1 in 300 times by HIV. In hepatitis B also, if the source, means the patient or the infected blood from where you have got it, is E antigen positive, then it becomes almost 20 to 30% chances, and very, very minimal blood is required for the transmission. So B is far more dangerous than C, and then followed by HIV. The reasons that B has a very good vaccine, so prevention is possible. C has a very good cure available, so treatment is possible. So dangerous out of them is HIV, since there is no prevention and the cure is also lifelong, and it's not a one-time eradication from the body is not possible. So the risk of transmission is by B more, but dangerous is more HIV. Now, as we say that whenever you want to talk, you must know your enemy well. So that is why I'll take you slightly about talking to you about hepatitis B and C virus. Hepatitis B is a DNA virus. We know that viruses are of two types, DNA and RNA. So B is a DNA virus. It is belongs to HepA-DNA viridae. It has a part. So the important antigens on its surface are hepatitis B surface antigen, which forms the most important diagnostic marker to check, to look for an infection in a person, surface antigen. Antibody to the surface antigen protects a person, and so hepatitis B vaccination targets formation of antibodies to this surface antigen, and active ongoing infection is tested by HPV DNA. So I've just broadly, because I know most of you are not microbiologists, so I've broadly brought about 3 important things for the sake of the post-exposure: surface antigen, antibody to surface antigen, that is anti-HBs titer, and HPV DNA. So this virus is pretty stable at the room's temperature, can survive for 4 weeks. So that is why, need to be taken about proper disinfection and other universal work precautions. How do we acquire? So why I want to tell you is that so hepatitis B is concerned with a chronic liver disease, because it can cause chronic infections. It does not get removed from our body for beyond 6 months, and can lead to damage the liver in the form of cirrhosis and hepatocellular carcinoma. Now, but that most of the chronicity depends upon the child, the age we have acquired. Now, most of the infection which is transmitted from mother to child, that is from at the time of birth or as early as 1 year or 2 years, then the chances that it will land up into a chronic hepatitis B infection is 95%. So, and in the adult, like once you are more than 20 years, the chances that you acquire hepatitis B infection and it becomes a chronic infection becomes less than 5%. So this is something good for us to know about this virus, is that as we grow older, the ability for our body immune response to clear the virus from our periphery is higher. So the chances of chronic infection will not be there if you acquire it via the needle stick injury. It will be less than 5% chances. So things to get scared, about this virus. You should not panic whenever you have a needle stick injury, because you will have a 95% chance that your body's immune response will be able to clear it. Now, only thing you have to keep it in mind is that once this virus enters, you may be able to clear it from your periphery. You may not have a chronic liver disease, but the virus will stay in your body for lifelong. So you have to take due precaution so that it does not affect your liver health. So that is the only thing you have to take care. Otherwise, our body immune system is very good enough that it can clear. Now, once you acquire this infection from mother to child or very early in your infancy, then the chances that you will have it will damage your liver is very, very high, up to 95%. And that is why in the childhood, our national immunization program, we always stress at birth hepatitis B vaccination. So for post-exposure prophylaxis, I just want to say that although it is very infectious, but our body can clear it. So it might not affect 95% chances that it might not hamper or it might not affect our liver health. Hepatitis C virus, on the other hand, is a simpler virus than hepatitis B. It is an RNA virus. It has got just one envelope and one protein against which the antibody. So the diagnostic test for hepatitis C is antibody to HCV, and active infection is checked by hepatitis C RNA. Now, it can survive up to 3 days to 3 weeks again on environmental surface, but the only thing is there is no active vaccine. However, cure is there. Now, this virus is more dangerous in terms of causing damage to your liver health, because now natural resolution of this infection occurs only in 20 to 30. So once you acquire it and you do not treat it, so the acute infections becomes chronic, there are 60 to 80% chance that it will cause cirrhosis of the liver and may proceed to hepatocellular carcinoma. So I just want to say is that though there is a very good effective treatment available, hepatitis C can cause more damage to the liver, faster damage to the liver as compared to hepatitis B. Now, how are these three, HIV, B, and C, different in terms of virology point of view? Now, as you can see, the HIV can, once you get an infection, it gets integrated into the host cell, so it remains a lifelong infection. Hepatitis B also, again, you have, it gets integrated in the form of CCC DNA and also integrated into the host DNA, and so it persists inside your body lifelong. So these two viruses are very difficult to clear from our body. However, hepatitis C is a cleaner virus. It remains just in the cytoplasm and does not have a stable genome in the form of any integration. So, good thing about HCV is that the cure is possible. We have very good all-acting antivirals which are all oral. So, no injectable, no interferon. It's all oral treatment is available for 12-week, 24-week, and the clearance of this virus is possible. So, that is something good. So what have we learned is that HIV is the most dangerous. There is no vaccine. Cure is also not possible and can become chronic. Hepatitis B, good thing is there is a vaccine and does not in adult cause liver damage to an extent that it can cause in a child. Hepatitis C can cause liver damage, is not easy to remove, but then you have treatment. So there are always good things about each and every virus. So what are the preventive measures? Now, whenever we are working on these infectious fluids, these bloods, what are the preventive measures you have? Before any exposure, one good thing is immunization. Unfortunately, we only have immunization or vaccination for hepatitis B. It is not there for C and HIV. And so that we avoid exposure, you have to have, you have to adopt to your universal work precaution, universal or standard work precautions. Why? Because you have to consider each and every patient is potentially infectious. So your standard precautions of wearing gloves, wearing eye shields, or safe disposal of sharps, proper waste management, proper sterilization of your equipment needs to be done. And COVID has taught us that we have to do this very, very stringently. Now, once the whole topic is that once the exposure has come, how to manage and do the monitoring, which I'll be stressing more. So first thing first, pre-exposure hepatitis B vaccination. So there are a lot of myths amongst people about hepatitis B. So I would just want to clear these things about hepatitis B. First, what is the data about how are healthcare workers vaccinated, not vaccinated? This is a study, like a compilation of various published literature, and you can see that doctors from various hospitals see just 55, 47, 3 who are actually totally complete giving a vaccination history. At ILBS, which is a dedicated liver, again, our complete vaccination history when we get at the time of recruitment or after on our annual health checkup, it's just 85%. So we really need institutional policies for encouraging the healthcare workers for hepatitis B vaccination. This is our data. So doctors are very good, very well vaccinated. Unfortunately, technicians, non-technical staff is never vaccinated. So again, you need to upgrade your vaccination. Hepatitis B vaccination, it is freely available or very cheaply available. Recombinant vaccine, 3 doses, 0, 1, and 6, which is given to look for that the vaccination is working. Ideally, in a non-healthcare worker setting, the CDC has removed, does not say that you should get an anti-HPS done, but those who are high risk like us, like healthcare workers, then after getting all the 3 doses, whether we are responder and non-responder, it is must. So we have to check an anti-HPS titer after 1 to 2 months, and must know your anti-HPS titer, because that indicates that our body can mount immune response against this infection. Now, once you have taken a hepatitis B, this anti-HPS titer weans down. Now, a titer of anti-HPS more than equal to 10 milli international units per ml. So 10 milli international units per ml is the unit that is considered as seroprotective, and then the person is only called as immunized. Now, if you have received all the 3 doses, we call the person as vaccinated. But if you can show that you have a titer, then only you are called as immunized. So there is a difference between vaccination and immunization. So a healthcare worker should always keep with him a documented proof that he has received 3 doses and has once, now mind it, once achieved a titer of more than equal to 10 international units. Because anti-HPS titer, it wanes over the time. There is studies which has shown that once you have taken a hepatitis B vaccination at birth, then only 16% will have more protective titer over the years. Usually 80 to 84% people will show less than. So you don't have to get your titer done. So once report that you are a responder is sufficient enough. You don't have to get it checked every now and then, so that to know. And the role of boosters is also not there anymore as per CDC, just 0, 1, and 6. Now, persistent immunity up to 30 years had been reported, though if you are immunocompetent or you have responded well, then you can have immunity up to 30 years or so. So only at the time of exposure, we get an anti-HPS titer done, because probably normally healthcare workers do not keep a documented record for that sake only. But if you had a documented record that you were vaccinated with 3 doses, then it is good enough. Now, if a person has does not know that, then you should not start if you have interrupted schedule. This is the latest CDC guideline, that if you have an interrupted, like you have taken just 0, 1 dose and you have not taken 3rd dose, so you do not have to start the vaccination series. You have to just start from where you have left it. So if you have just taken 1st dose, immediately give 2nd and 3rd, and at least maintaining a gap of 8 weeks between them. And if you have not taken the 3rd, then immediately give a 3rd dose. Now, mind it that if you have taken a partial vaccination, like 1 dose or 2 dose, and you have got an anti-HPS done and it has come more than 10, but that will not be protective. So ideally, you have to have a documented proof of complete vaccination, means 3 dose, 0, 1, 6 or 0, 1, 2 if a fast schedule, and then only a documented proof of more than 10 will give you a protection. Otherwise, if it is after 1 dose, more, some people may be responding earlier, but that will not give you a good protection. So normally what we do, this is just a flow chart to tell you how we do at the time of recruitment. We check for an anti-HPS. If you have it at less than 10, so you can give 1 dose, so that and look for the titer. Now, if a person you have administered complete series and still the person has not mounted a good immune response, then we call it as a non-responder, and then we tell them to take due precaution for against all kind of exposure. So this is about the vaccination, because I think this is grossly lacking in most of the institutes. So each institute, before going for a post-exposure, they should have a very good pre-exposure institutional plan also, and especially for the hepatitis B vaccination. Now come to the actual topic. Now, what happens that if you finally, I mean, despite your vaccination, you have got an exposure, everybody here and there can get an exposure. So what to do? Now, what are the factors which can influence your risk of infection? So what is the type of body fluid? We know that there are certain body fluids where they are non-infectious, like feces and all. So what is the type of body fluid? The amount of the blood or the fluid that you got exposed to. The type of needle or sharp is also very important, whether it was wide gauge or narrow gauge or this thing, so that the degree of exposure depends upon the type of the needle. The depth of injury, which is really pierced hard, there's a lot of transmission of blood onto the surface, then that also depends, chances of infection becomes more. The infectivity. Now, from where you have got it, that person's viral load status is also very, very important. So these are the factors. What are the practices? We know that recapping has been the most, when a person just takes blood, does it and recaps, that is the most important risk factor for having or practice by which you can have needle stick injury or exposure. If you're not disposing them properly into the proper containers and just into the general trash like this, the needle coming out, and poor waste management practices. So each institute should have a very good waste management and sharp management policy so that you prevent. At ILBS, when we saw again the same needle stick injuries are retrospective analysis of data, we saw that recapping of needle was the most common cause of these incidents to occur, and the recapping occurring in the ward. So when we are working in a ward, we become slightly complacent, that we might not, we are at ease, we are talking and doing our work. When you are in OT in ICU, you are actually wearing gloves and adhering to all your universal work precautions. So working in the ward and recapping is the most important and dangerous activity. Now, what are the reasons? Now, we just did a survey that why healthcare workers do not come forward and report the accidents to hepatitis B and C. As you will be amazed to see our data, that they believe that if we do not have HIV infected source at our institute, then there is no risk for us for any post-exposure. So when I started the work here, most of my other healthcare workers used to say, we do not get HIV patients here. So what is the need of having these post-exposure prophylaxis classes? It took me a long time to tell them that B and C are equally harmful, and you need to take care of hepatitis B and C infection. It's not only HIV. Then the other thing is that we are hepatitis B vaccinated, so we do not need to, we will not have any problem. That's wrong, because hepatitis B vaccination is for hepatitis B. But what about hepatitis C? So that is why, so we found that the hepatitis C needs to be told to our students as well. And so in post-exposure management, you have 8 steps. First is the management of the exposure side. That is the first aid you give. Then reporting. Reporting is very, very important, because I told you that if you do not report, proper necessary action will not be taken. Risk assessment, then post-exposure prophylaxis, counseling, lab evaluation, then initiation, follow-up, and then documentation is also very, very important. So what are do's and don'ts? So I'll stress upon the don'ts. Do not panic. As I told you, how good each of these viruses and what all mechanisms we have. So do not panic. Do not put your finger into your mouth and do not squeeze, so that you harm more capillaries surrounding that wound area and allow the virus easy entry or capillary suction of the virus. And do not apply strong disinfectants or sterilize, to your surface of the wound, because that will further damage your small capillary circulation there and will allow the virus to penetrate. Immediate reporting then comes next. Now, the degree of exposure is that we do assessment that whether it is mild, moderate, severe. There is a definition for each, and you can actually label that whether the exposure is of which category in a healthcare worker. Counseling is very, very important. So to have a infection control team and a person who is looking after these and then counsel, because sometimes there is no counseling team, there is nobody who can talk to, wrong things can go and wrong decision can be done, and they do not proceed in that systematic manner. So the counseling and algorithm by which they have to proceed for further tests is very, very important, I'll tell you. Now, what are the tests to be done? In case of source, so we are calling source as a person from where you have got the infection. So immediately, and all these reports have either the patient has a report within a week or not later than a week, and or you get it tested immediately for hepatitis B surface antigen, antibody to HCV, and antibody to HIV 1 and 2. Now, a person who is exposed, a healthcare worker, their baseline information is also very, very important, because in case you turn out to be positive later on, but you were prior to exposure, you were positive. So that all depends upon, assessing your case. So that is why this test of HPSAG, anti-HCV, HIV 1 and 2, and anti-HBs titer we do normally. As I told you that there is no need, but at the time of exposure we do it, because most of their healthcare workers, they do not remember and they do not have a documented. So if a healthcare worker has a documented proof that, see, my anti-HBs titer a month back was this, then there is no need to do this anti-HBs titer. You can have a documented report of a healthcare worker's anti-HBs titer, then there is no need to do it at that moment of exposure. There are certain other tests, then depending upon case to case, we sometimes decide if there is a high level of exposure, like HPV viral load, on source, liver function test of the healthcare worker, and CBC in case you have to start your HIV treatment. Now, this HIV, I think, must have been taught to you, so I'm not going to speak about it. Only thing is that the window period is that it should be started as early as possible, post-exposure prophylaxis for HIV within 2 hours, but not beyond 72. So this is crucial. This is the golden window of 2 hours within which you have to start. Now, post-exposure prophylaxis for hepatitis B, the ideal time frame is 48 hours of exposure, although it can be considered up to 1 week. So if you have to give any immunoglobulin, then it should be best within 48 hours. Can be given up to 1 week, because beyond 1 week, if you give, then there is no role of these immunoglobulins. So best is within 48 hours, but not later than a week. Now, complete series means 0, 1, and 6. Try to have a 0, 1, 6, not the accelerated vaccination for a healthcare worker, and the dose of immunoglobulin is 0.06. Now, only one thing is, I would like to say that this is an interesting case scenario, that all your evaluation of the healthcare worker and testing should be before you have put in any post-exposure prophylaxis or immunoglobulin. So this I really want to tell you that, please, if you have administered HPV vaccination or HBIG, then HBsAg testing or anti-HBs titer should not be done, or HBsAg testing, if you have given a vaccination, should not be done at least for 2 to 3 weeks. So this was an interesting case scenario. A resident came to me from Safdarjung Hospital, that he comes to me and says, I'm HBsAg positive. Day before yesterday, I had my needlestick injury, and now I'm HBsAg positive. And he was all panicked and sweating. So I just made him sit down and I asked him what all actions and steps your infection control team did. So he told me that there was a needlestick injury from a hepatitis B positive source. They immediately gave me 1 booster dose of hepatitis B, and then I went to lab, and then I gave my blood sample for HBsAg testing, and it immediately told me that this is a false HBsAg positive. But imagine that 2 days that resident was in the sleepless mode, and he was panicking that how come I am hepatitis B positive. So these care has to be taken by the lab people. That please do not refrain from testing for any anti-HBs titer or HBsAg if you have given a vaccination or you have administered immunoglobulin immediately. Now, how we go about it? So, as Professor Khan was saying, immunoglobulin administration is done only in cases where it is needed, not in all. It is not it should not be a universal practice. Now, first is that if a person has a documented responder, he has got a complete vaccination series of hepatitis B and has a documented more than 10 response, no action needs to be done. No post-exposure prophylaxis for hepatitis B. First thing. Now, if it is a documented non-responder, which I told you that you have given 2 complete series and still the person has never shown any anti-HPS titer. So in that case, only if the exposure is from a known positive hepatitis B surface, immediately 2 hepatitis B immunoglobulin needs to be administered. So this is the only strong indication. So first thing you have to check for the patient, the healthcare worker's response, whether he has a series of vaccination, whether he has a documented, and that is why at the institute, we keep all the records of our healthcare workers. If he is a known non-responder, please go ahead and give him immunoglobulin shots. It is needed within 48 hours. Now, if the response is not known, he has said that I have taken 3 vaccination, but I do not know the response, immediately take his sample before giving immunoglobulin for an anti-HPS. Before giving immunoglobulin, take his blood sample for anti-HPS to know. If it is less than 10, give 1 immunoglobulin and proceed for a revaccination with the complete doses. If the exposure is from a positive source, so it means that there is a positive exposure and the person has got a complete series but does not know his titer, first thing, take a blood to measure his anti-HPS titer, then give him an immunoglobulin, and then also give him all 3 complete 016 vaccination. Now, if the exposure has taken place and the source is negative, then you don't have to give immunoglobulin. Only thing is that you just give booster dose so that you check his anti-HPS. If it comes to be less than 10, then you just give 1 booster dose and then recheck. Or if it does not come out, then you can go on status. Now, if he shows you a more than 10 at this time, no need. So more than 10 milli international units titer, if a person has got no post-exposure prophylaxis, I'm again and again telling you, and this should be boldly told and taught to all the clinicians, so that do not go ahead and start giving your immunoglobulin immediately, because each vial of immunoglobulin costs about ₹1,00,000. So please do not panic and do not give immunoglobulin. Now, if the person has never been vaccinated, incomplete vaccinated, or they have never taken, and the exposure is from a known positive, then please give just 1 dose and you complete the vaccination and then follow up, as I'll tell you how to follow up. But if the exposure to a person is from a source is negative, then nothing to be done, just complete his vaccination. Now, this is from the latest recommendation. You can all see this, MMWR 2018. After that, no other recommendation. I hope this is clear when to give immunoglobulin and vaccination. Now, hepatitis C. Now, there is no post-exposure prophylaxis for hepatitis C. Only thing is that we do some assessments and follow-up. So if the source is anti-HPS negative, nothing to be done. But yes, if the source is anti-HCV positive or unknown, then you first check for his anti-HCV titer. If he is positive, then you have to confirm the HCV status in the form of active infection RNA, and then you just have to do a follow-up. So you can do a baseline testing of the healthcare worker within that time, and then keep on doing the follow-up. Follow-up can be done by doing an RNA in the healthcare worker at 3 weeks. If the person is very anxious, then you can check his blood for 3 weeks RNA, or antibody at 1 month or 6 months time. Up to 6 months you have to follow up. So you just, if the person is very, very anxious, you just do on the healthcare worker, that is the exposed HCV RNA at 3 weeks. This is the golden, because do it as early as possible, but not as within first week, should be done by 3 weeks. And if the person, or antibody at 4 months, followed 4 weeks, followed by 6 months. If any time the person develops, becomes either RNA positive, anti-HCV positive, that means he has just got an acute HCV infection. 20 to 40% chances are that he can clear the infection. So this depends upon hepatologist to hepatologist. They normally evaluate for your liver function test. They can also allow you to wait for 6 months for naturally the virus to clear, or they may give you, they may treat you like an HCV infected and may give you antivirals, which are all oral antivirals for a 12-week, and let the virus clear from your body. So nothing to be done. We only wait for an acute HCV infection in the healthcare worker to develop, and then tackle this acute HCV infection like the way we tackle any HCV in any person. Monitoring, following up is done for any kind of exposure up to 6 months. Normally it is done at 6 weeks, 12 weeks, and 6 months. You tell them to follow certain precautions like avoid blood or tissue donation, breastfeeding, unprotected sexual activities, or becoming pregnant following the needle exposure. If you develop any febrile illness within this, and or any other side effect, then person must come and be counseled. So how much is the monitoring? For anti-HCV, 1 month you have to do an antibody, or if you have an RNA arrangement available, then 3-week RNA arrangement to be done. Follow the patient that he has developed or any acute infection, and treat accordingly. Now, documentation is very, very important. What was the type of exposure? What is the procedure? All this documentation needs to be done. Now, talking about how you can prevent them. Now, so this is, I hope it is clear, the management of hepatitis B and C. I'll again revise with you that hepatitis B is all vaccination and immunoglobulin administration, but checking the status of the healthcare workers' anti-HBs titer, as well as source hepatitis B surface antigen. HCV, nothing to be done, only follow up. Wait for the healthcare worker to become HCV infected, and then you treat accordingly. Now, what are the other preventive measures? One of the most important is the training to be given to your healthcare workers regarding the safety of injection procedures, how to dispose shaft. Now, you also have these safety engineered devices by which you can prevent, like recapping, etc., and exposure can be prevented. So reuse prevention syringes are available, where automatically you can put in the cap, so it is not, you need not do the recapping, or you have those which have a protective shield, or the needle itself breaks, or it has a blunt needle. So there are a lot of safety engineered devices which are there, I think, which should be a practice for us. We also have this Needlestick injury website. If you post any of your queries there, we can, and we have uploaded few guidelines and videos. You all can visit this and see for it. Now, just a brief thing about what turning the table, as I told you, if our healthcare workers are infected. So unfortunately, in India, we do not have any regulatory guidelines on management of infection in the healthcare worker, but we only have 2 or 3 societies like the SHIA guidelines, the CDC and UK guidelines, which says now, so normally HIV, if the person is, you do not prevent them from joining the healthcare profession. Only thing care to be given is that if a person is HIV infected, then you just have to maintain the HIV viral load, that it should not be 1,000 copies in certain societies, or it should not be more than 500 copies in certain. For HBV, HCV, you try to maintain the viral load less than 1,000 as per most of the guidelines. And the E antigen, some of the guidelines say that should be negative, but SHIA says it's not required. However, only the UK guidelines say that the healthcare worker should have a viral load less than 2,000, as well as should be E antigen negative. And you should do such healthcare workers the testing quarterly or twice yearly. And you can keep on following, but unfortunately you do not have, there is no mandatory testing of the healthcare workers at the time of joining, and you do not have these guidelines in India. So in the summary, I would like to tell you that healthcare workers needs to be aware about the mechanisms by which you can acquire these bloodborne viruses. Prevention is always better. So universal work precaution, hepatitis B vaccination, which I'm again and again telling you, and please have a documented evidence of your anti-HPS titer with you, because that will help you. In case you have an exposure, please do not panic, because we know how easy it is to manage. The viruses are not that harmful, but you just need to have an algorithmic approach. Stepwise management is important. And there is a time now we should have national guidelines for healthcare workers' safety in case the healthcare workers are infected and management. So I thank you all. Thank you.
Thank you, Ekta ma'am, for such an insightful session. We have few questions in the chat box. There has been a question related to the cutoff of anti-HPS titers in health workers.
Which I have said, 10 milli-international units per ml.
He still persists and asks that for health workers, it is around 100
No, there
international units.
are, see, the CDC guidelines and all the guidelines say 10, but however, there are published literature which is available that more than 100 gives a very good protection for hepatitis B. So it's, some institutes say that we try to follow more than 100, but as far as the CDC and other guidelines, it is just the 10. So there are no changes in these national and international guidelines. Out of published literature, yes, some people say that more than 100 is preferable for people who are doing high risk exposure prone procedures, EPP.
Thank you, ma'am. Now we have another question. They have asked, what if the vaccine dosage is given in the triceps instead of deltoid due to inexperienced nurse?
I think that is not for a microbiologist to answer. So normal insertion is deltoid, intramuscular. So intramuscular should work well. Out of my domain. So maybe it's intramuscular, so any muscle. So it's okay. Yeah. You can have all other injuries associated with improperly administered doses. Not my domain. Yeah.
Yes, ma'am. Thank you, ma'am, for the wonderful session, and thank you for answering the questions. I would now ask Shruti to continue.
Thank you so much,
Shruti.
ma'am. It was a wonderful, excellent session, and I think the students, we have seen in the pre-assessment that you have covered almost all the points. There was they were lacking. Thank you so much.
Thank you,
And there's
Fatima.
one more.
Yeah.
There's one more query. There's one more query in the chat box, as I have seen. Someone has asked if they are not vaccinated previously, then as a medical student, are they supposed to get themselves vaccinated? And I think the answer should be yes. They need to be vaccinated.
Yeah, so I told you the interrupted vaccination schedule. The vaccination schedule of 3 vaccines, 0, 1, 6 needs to be done. Now, this is very often asked from me that I have got 1 and 2 and I measured my titer, it is more than 10. But that can be your premature immune response, but may not be protective in the long run. When you are given a good vaccination 0, 1, 6, and then you show more than 10 titer, protection up to 30 years that has been documented. So always encourage 3 doses, then only anti-HPS titer.
And ma'am, some more queries that we get from our postgraduate students sometimes, that they have taken 2 doses and now 2 years back, and what about continuing the vaccination? Then we say that you just take the 3rd dose.
Yes.
Do we give you the correct advice? Are we giving them correct advice?
Yeah, you're doing it. I showed you. These are the latest CDC guidelines, 2018, interrupted dose. So proceed with the vaccination, finish the interrupted dose as early as possible.
Okay. Ma'am, is there any maximum time limit for this interrupted vaccination? The maximum
that they
gap?
have not, no, that they have not mentioned. Now, it can be that if you do not remember, then you can revaccinate with 016. So if there is such a long time gap that they do not, then I think it's always better to revaccinate, considering that they do not remember. Exactly.
Okay. Thank you so much, ma'am. Thank you.
Okay. Can I log out?
Yes, ma'am. I think.
Okay.
Thank you so much.
Thank you, ma'am.
So moving on, I would ask Shruti to carry on. Shruti.
Thank you. Now I would like to introduce Dr. Fatima ma'am. Dr. Fatima ma'am is working as an associate professor in the Department of Microbiology, JNMC-AMU. She is also in charge Central Sterilization Unit, JNMC-AMU, and convener Biomedical Waste Committee and Antimicrobial Stewardship Committee, JNMC.
Shruti, shall I share my screen now? Start kar de session.
Yeah, ma'am, sure.
Okay. I hope I can share a video before I start with my presentation. The Clarinet team, can I share the video? Chal jayega na video? This video was donated to us by Dr. Sumi Nandwani from ESI Hospital, and it had a great impact on many of the healthcare workers जिनको भी हमने दिखाया है. So I just think it will be good for you people to see this video. It is neither in Hindi nor in English, but it makes a great impact on the viewers. So let us start with this.
நந்தினி இங்க என்ன பண்ற? நான் பேச்சு போட்டியில ஃபைனல்ஸ்க்கு செலக்ட் ஆயிட்டேமா. அப்படியா கண்ணு? இதுல மட்டும் நான் ஃபர்ஸ்ட் வந்தேன்னு வெச்சுக்கோயேன். டெல்லியில ரிபப்ளிக் டே அன்னைக்கு பிரசிடென்ட் கையெல்லாம் கொடுத்து பிரைஸ் கொடுப்பாங்களாமா.
What is this, sister? Hospital nursing சத்திரம் nursing. Patient help பண்ணலாம்னா பரவாயில்லை. Atleast டிஸ்டர்ப் பண்ணாம இருக்கலாம்ல.
அடுத்த வாரம் ஸ்கூல் ஃபீஸ் கட்டணும். ஞாபகம் இருக்குல்ல? கேட்டுச்சா? இந்த வாரம் சம்பளம் வந்துருங்கன்னு இந்த வாட்டி டயத்துக்கு ஸ்கூலுக்கு வந்து கட்டிடுறேன். இத்தோட 458வது தடவை சொல்றேன். ஸ்கூல் இல்லமா ஸ்கூல். எங்க சொல்லு? ஆமாண்டி, எங்க அப்பா அம்மா கான்வென்ட் ஸ்கூல்ல சேர்த்து விட்டாங்க பாரு. இந்த மணி ஆகுது, கிளம்பு. நந்தினி, நந்தினி, பாத்து கவனமா போ பஸ்ல. நந்தினி.
வேலைக்கு போல உடம்பு சரியா?
அதெல்லாம் ஒண்ணு பெருசு இல்ல. சாந்தமா, சாந்தமா, ஐயோ சாந்தமா.
அடுத்து சில்ட்ரன்ஸ் கார்டன் பள்ளியின் சார்பாக நந்தினி எஸ் பேச போகிறார்.
ஏமா உங்க வீட்டுக்காரர் எங்கேயாவது சமீபத்துல பிளட் டிரான்ஸ்ஃபியூஷன் எங்கேயாவது ரத்தம் ஏற்றுனீங்களா? இல்ல யூஸ் பண்ண சிரிஞ்ச் ஏதாவது கையில பத்தி அந்த மாதிரி ஏதாவது யோசித்து பாருங்க.
2-3
உங்களுக்கு வந்திருக்கு மஞ்சள் acute hepatitis B.
ஜெயிச்சிட்டேன். சிஸ்டர் ட்ரெயின் டெல்லி பிரசிடென்ட் பார்க்க போறேன். அம்மா எங்க? அம்மா வார்ட்ல இருக்காங்கம்மா, அட்மிட் ஆயிருக்காங்க.
ட்ரீட்மெண்ட்டுக்கு ரொம்ப லேட்டாக கொண்டு வந்திருக்காங்க. பொதுவாக மஞ்சள் கம்மல்னு சொல்லுவோம், அவங்க ஹெப்பாடைட்டிஸ் பி அப்படின்னு சொல்லுவோம். சரி, அம்மாவை பக்கத்துல இருந்து பார்த்துக்கிறதுக்கு யாரும் இல்லையா?
அது எப்படி அம்மாக்கு வந்துச்சு?
ஏற்கனவே இன்ஃபெக்ட் ஆன ஒருத்தருக்கு குத்தின ஊசி யூஸ் பண்ண நிறைய வழி இருக்கு பரவாயில்ல.
எப்படி அந்த ஊசி
ப்ரைஸ் வின் பண்ணிருக்கியா? என்னாச்சு?
அம்மாவை பார்க்கலாமா?
So welcome back after the video, and I hope the message is clear to all of you why I shared this video. It is our responsibility as healthcare professionals. Although most of you are still undergraduates, but one day you'll be becoming residents. And as healthcare professionals, our duty is primum non nocere. That is, please do no harm to yourself and to your patients. And with this, let us start my presentation. Because it is always easy to prevent any infection than to cure it. So I'll be talking about the post-exposure prophylaxis, and it is not an easy task for the post-exposure of prophylaxis of HIV. Dr. Ekta has very nicely covered about the post-exposure prophylaxis of hepatitis B and hepatitis C, and see how many times did she stressed upon the fact that although we all know that the transmission of hepatitis B is highest amongst all these 3 major blood-borne viruses, but still we have a vaccine for hepatitis B. For hepatitis C, we have a proper drug regimen so that it can be cured. For HIV, it is a social stigma, and the treatment is also not like the patient will be cured for life. So it is very essential to take proper prophylaxis, proper standard precautions for all the patients, irrespective of hepatitis B, HIV, HCV. We have to follow the standard precautions for all patients so that we protect ourselves from getting these accidents. Now I'll be talking about post-exposure prophylaxis and what do we understand by post-exposure. Post, you all know it is after. Exposure is a situation where HIV has a chance to get into someone's bloodstream, and prophylaxis is a treatment to stop an infection happening after the exposure. But again, I'll stress that our aim is to prevent this exposure from happening. That will be our first priority. We have to follow these standard precautions so that we don't need to take this post-exposure prophylaxis. Now, when do the needle sticks, they happen usually? Before and during surgeries, only around 20%. During and after disposal, 10%. After use and before disposal, that is during transportation or during recapping, as ma'am said, the maximum chances are during the recapping. That is after the healthcare worker has done the procedure that is required and before disposal of that sharp. Majority of the injuries that happen. And we did a study in which we noted down the time when the risk of exposure were highest. It was in the early morning. That is when the healthcare workers, they're most stressed out after the whole night duties. The chances of exposure, they were highest. So the practices that influence the risk of these exposures are, as mentioned earlier, recapping of the needles. Most important, majority of the needle stick injuries, they happen while trying to recap the needles. So please remember, never ever try to recap any used needles. If it is essential to recap a needle, then we have to use a single hand technique for recapping of the needles. Then handling and passing needles or sharps after use, particularly in the OTs when the surgeries are going on, then everyone is in a stress, then these injuries may happen. Then failing to dispose of used needles properly in puncture-proof resistant sharp containers, as we have seen in this video. And we have seen in this video how it impacts the entire life of a family if we do not dispose our sharps properly. Then poor healthcare waste management practices. When the healthcare waste is not segregated, again, it increases the risk of exposures. So how can we prevent? Again, ma'am ne kai baar stress kiya. Again, I'm stressing, follow the universal precautions for all patients at all times, irrespective of their HIV, HPV, and HCV status. We have to consider all the patients as infectious unless and until proved otherwise. Then avoid recapping of the needles. Plan for safe handling and disposal of needles after use, and properly dispose used needles in appropriate sharp disposal containers. Basically, we have to follow the universal precautions, and particularly the sharp safety and the biomedical waste management practices. And most importantly, as ma'am again has stressed, regular training on infection control practices, because training plays a very important role. It comes in our instincts to dispose the needles in proper containers. Jitni baar training hogi, it becomes a regular habit to follow these infection prevention practices. So this is a chart which shows the biomedical waste management rules of 2016. And as you can see, the white container, which is the puncture proof container, should be used for disposal of all these scalpels, blades, needles, syringes, any sort of sharp, and the blue container for the broken glassware. So these two are the favorite ones for when we are talking about the sharps. Blue for the broken glassware and white for any sorts of needles, blades, syringes, scalpels. तो इन दोनों को हमें याद रखना है for our disposal of the sharp waste. And again, please use needle cutters for disposal of the needles. We have to destroy the needles in our needle cutter before we dispose them. If needle cutter is not available, then as shown in the previous slide, we can dispose them in the white containers. So, and never ever try to recap the needle, bend the needle, remove the needle. Do not transport the needle. The needle cutters, they should be available at the site of patient care, jahan par we are doing any processing of the patient sample or whatever action we are doing for the patient. The biomedical waste containers and the needle cutter should be present there and there, then and there only, and we have to destroy the needle there. If we transport the needle to any other particular point, then the chances of needle prick injury, they increases. And please do not ever try to reuse any sharp, any needles. So the sharp disposal containers, they should be available at the patient care sites. Again, do not walk around the area carrying syringes only or even for trying to dispose them. And do not manually sort medical waste. We always say that the segregation should be at the point of generation. If segregation has not been attained, then we are not supposed to segregate it afterwards. So this is the container which should be used for disposal of the needles to prevent the transmission of this needle stick injuries. Then it is not only the needle stick injuries, it is exposure to a number of other body fluids also, which can lead to exposure to HIV, HPV, and HCV. So just have a look of the potentially infectious and non-infectious body fluids. So the potentially infectious body fluids are blood, semen, vaginal secretion, cerebrospinal fluid, synovial, pleural, pericardial, and peritoneal fluids, and the amniotic fluids. So these are the body fluids. If any healthcare worker, or in that case, any person who is exposed to any of these secretions, then he or she will be at risk of exposure to these bloodborne viruses. In contrast, tear, sweat, urine, feces, saliva, sputum, and vomitus, these are the fluids which are considered as not at risk body fluids. However, if any of these fluids also is contaminated with visible blood, then they should also be considered as at-risk body fluids. Then what is post-exposure prophylaxis? This is from where we started. It is after the exposure has occurred, the treatment that has to be taken is considered as post-exposure prophylaxis. Now the question is, what is exposure? What is the condition when we'll say that a healthcare worker has been exposed to HIV, HPV, or HCV? So in exposure, in most of the times, it is a percutaneous injury, that is a needle stick or sharp or cut with a sharp instrument. Apart from percutaneous injury, it can be contact with the mucous membranes of the eye or mouth, or contact with non-intact skin, or contact with the intact skin also for prolonged duration of time and with large amount of blood. Then even with the intact skin, we'll consider it as exposure. Then the other question is, when is PEP recommended? Are all the exposures they require post-exposure prophylaxis? The answer is no. All exposures, they do not require post-exposure prophylaxis. We have to see the source code, the condition, the source code, and the amount of blood that is present, in amount of virus that is present in the blood of the patient, and the amount of and the type of exposure that has occurred. Uske hisab se we have to weigh, and then we have to decide for the post-exposure prophylaxis. So the risk of infection, it varies with the pathogen involved. As mentioned earlier, it is the hepatitis B virus which has highest chances of transmission. The type of exposure, deep pricks with hollow needles, they have highest chances of exposure. The amount of blood that is involved in the exposure, as mentioned in the earlier slides, even in intact skin, if the amount of blood is very large, then and the duration of exposure is long, then even with the intact skin, it can be considered as being at risk. Then the amount of virus that is present in the patient's blood also plays a role in the transmission of risk of infection. The thing that we need to remember, most of the healthcare workers, is that most exposures that do not result in infection. So this is the graph which shows the relative risk of transmission of infection after a percutaneous injury. We are discussing about percutaneous injuries because maximum chances of transmission of infection are after a percutaneous injury. As you can see, it is lowest by HIV, followed by HCV. And if for hepatitis B, if the patient is HBe antigen positive, then the chances are much higher as compared to if the patient the source is HBe antigen negative. But again, I'll stress again, because HIV, we do not have a vaccine, and the stigma is very high for HIV. So the healthcare worker, they panic much more if they are exposed to HIV. So the first thing that has to be followed in case an exposure occurs to a healthcare worker, irrespective if it is HIV, HPV, or HCV, the first thing is, please remember, we have to keep in mind that do not panic. There's no need to panic. Only about 1% of the exposures, they lead to transmission of infection of any HIV, HBV, HCV. Majority, 99% of the times, it is not transmitted. But we have to take the precautions. Wash the wound with and skin with soap and water. Do not use any antiseptic. Do not use any disinfectant. Do not press the site. Do not lick it. As ma'am told, do not try to lick it with your mouth. Do not press it, because when we try to press, then there are micro injuries that occurs in the micro vessels, and the virus, it gets a chance to move upwards. Flush the mucous membranes with water. If exposure occurs in the eyes, then wash it with large amounts of water, generous amounts of water. Wash the eyes. If the person is wearing contact lenses, then again wash with plenty amount of water. After washing, then remove the contact lens. Do not try to remove the contact lenses before washing it with water. Do not squeeze the wounds or use antiseptics or any type of disinfectants. And please, again and again, I'm saying, do not panic, because I am the infection control officer. I receive phone calls from my postgraduate students. They know all the theory about the post-exposure prophylaxis. They know that they are supposed to wash hands with water, soap and water. But when they come to me that, ma'am, they usually come, ma'am, I have been exposed to a patient who was positive with HIV or HPV or HCV, and I did not wash my hands. I was in so much of panic that I didn't remember that I was supposed to wash my hands with soap and water. I just thought that I'll call you, and so that you may guide me what to do. But instead of calling me or calling any other person, the first thing we are supposed to do is to wash the hands with soap and water and remain calm. Then the second step is, after you have taken the first aid, this was the first aid that we were talking about. After the first aid has been taken, we have to assess the risk of transmission of infection. We have to see what is the exposure risk and what is the status of the patient. So it depends upon the type of exposure that has occurred. That is it a percutaneous injury? Is it a mucous membrane exposure? Is it an exposure on the non-intact skin or the intact skin? So depending upon that and the status of the patient, if the patient is HBs antigen, E antigen positive, E antigen negative, if CV antibodies are present or not, presence of HIV antibodies. So this way we have to assess the exposure risk. For HIV, the exposure risk can be categorized into mild, moderate, and severe. Mild is exposure to mucous membranes, non-intact skin, and intact skin. Moderate is exposure to mucous membrane or non-intact skin with a solid needle. And severe is percutaneous exposures or deep pricks. For the source code, it is HIV negative, low risk, and high risk. So we have to weigh the source code and the exposure risk, and depending on this, we have to decide the post-exposure prophylaxis regimen. This is a very complicated chart, but this is the chart which we are supposed to follow once the exposure occurs. So if a healthcare worker is exposed, we have to see that whether the material in the blood, body fluid, or other potentially infected material or instrument contaminated with one of these substances. If yes, then what was the type of exposure? As mentioned earlier, iske hisab se we'll decide the exposure code. If it is mucous membrane or skin integrity is compromised, then we have to see the volume of the blood. If volume of the blood is small in amounts, then the exposure code is 1. If it is large amounts, then the exposure code is 2. If percutaneous exposure has occurred, then the severity is to be considered as less if it is a solid needle, and it is to be considered as high if it is a deep hollow needle. If the skin is intact and the amount of blood is less and duration of exposure is low, then no PEP is required. So this is the table which shows the exposure code and the source code. According to this table, we have to decide the PEP regimen of the patient. So if the exposure type is less severe, then a simple primary regime of tenofovir, ampicillin, and raltegravir has to be given for 28 days. If the exposure code is high, then we have to give it again for 28 days. The other thing that we have to remember is that, as ma'am said, the post-exposure prophylaxis should begin as soon as possible, and it has to be given within 2 hours and not beyond 72 hours. And for HIV PEP post-exposure prophylaxis, particularly, we have to go for the counseling of the patient, because HIV post-exposure prophylaxis it comes with a number of side effects, and most of the healthcare workers, they just drop out of this post-exposure prophylaxis. So we have to counsel the healthcare worker beforehand that a number of side effects may occur. There may be nausea, there may be other side effects. The only side effects when the PEP has to be stopped is jaundice. If the healthcare worker, he suffers from jaundice, then we have to stop this regime before 28 days. Otherwise, he or she is supposed to follow it for 28 days. Then a number of baseline tests are to be followed. The baseline tests, that is at the time of exposure, HIV, HBV, HCV status of the patient and of the healthcare workers, then the blood counts. Then again, the healthcare worker has to be called at 2 weeks and 4 weeks, then at 6 weeks, at 3 months, and at 6 months. So we have to follow the healthcare worker for 6 months duration for the follow-up counseling. And this is the, again, documentation. Any needle stick injury, if it occurs, then it has to be documented to the healthcare officer, to the medical officer in this proforma. So basically it is, again, I'll stress, it is the universal precautions that we are supposed to follow. And that is safe injection practices, follow hand hygiene, consider all blood samples as infectious, follow the universal precautions for all patients unless and until proved otherwise, safe handling of the sharp instruments, and use needle destroying machines. And safe one injection at a time, one needle, one syringe, only one time. So that is it. Keep calm and primum non nocere. Thank you.
Thank you so much, ma'am.
You're welcome.
If you permit, can we have the polling session?
Sure.
Yeah.
I hope that we'll have better results after these sessions. Can we compare the results before and after?
Yeah. I request Fiona to please can we get the comparison from pre and prior call?
Yes, ma'am, sure.
Please start the poll. There is a query in the chat box. I can see that if I don't know if I was vaccinated as a kid, so should I get vaccinated as a precaution? Yes, you are supposed to get yourself vaccinated. If it is not, your vaccination is not documented, then all the 3 doses you are supposed to take for hepatitis B. There is another query from Dr. Rahul, I think, that after complete series our antibody titer was not checked, and so we need to do it again for documentation. Ideally, the antibody titer, it should be done after 1 month of vaccination and within 4 months after the vaccination was complete. But if it was not done at that time, then you can do it now. But ideally, 4 mahine ke andar we should get it done. But if it was not done at that time, though, you can go for it now. And once you have achieved a titer of 10 or more, then you are protected for life. I think this is enough time for the poll. If you have received the entries, Clermont, can you please?
Okay, ma'am, I'm just ending the poll.
Sure. And please show us the results.
Yes, ma'am. I'm sharing the results.
Oh, okay. So we didn't answer the first question actually. The 2 vaccines mandatory for all healthcare workers, they are hepatitis B and tetanus. It is hepatitis B and tetanus. Oh. These results are of the post-event. These poll results.
Ma'am,
These poll results, they are post-event results, or they are the first ones.
ma'am, this is for poll 2. Poll results, ma'am.
Poll results post-event or pre-event?
Ma'am, it's post-event.
Post-event, okay. So let us just discuss this poll also with the participants before we go. So I have answered the first question. The two vaccines which are mandatory are hepatitis B and tetanus. Which of the following infections has maximum chances of transmission? ये तो हमने कई बार discuss किया. It is hepatitis B. Hepatitis B has maximum chances of transmission through blood. It is approximately 30% and only 3% for hepatitis B and 0.3% for HIV. So there is no doubt in this answer. It is clearly hepatitis B. What is the first thing to be done after needle prick injury? It is rinse with soap and water before any vaccination, before reporting, before getting any post-exposure prophylaxis. The first thing to be done is please wash it with plenty of soap and water without pressing, without taking doing anything else. What is the next thing everyone should go do after your vaccination? And booster dose is not recommended now. It is only a 3-dose regimen which is recommended. That is the 0, 1 and 6. Booster dose is not in the schedule. So only 3 doses followed by checking your antibody titers after 1 month of the complete vaccination and preferably within 4 months after the vaccination has been complete. So there's no role of any booster dose. Please, participants, please remember there's no booster dose. Again and again, I'm repeating. Then possible modes of hepatitis B virus transmission. We all know this. It is through contaminated blood, through needle prick injury, through sexual route. It is all of the above. It can be transmitted through all these routes. Then how can you reduce the chances of needle prick injury? By please do not, never ever recap, never bend the needle. Safe transportation. No, there is nothing like safe transportation. Do not try to transport the needles in shops. It is simply by destroying the needle in a needle cutter. Or if needle destroyer is not available, then dispose it in the puncture-proof white container. Never try to recap. Again, I'm repeating, never bend and never transport a needle. The needle and sharps, they should be discarded in which bin? I have answered this. It is white bin. Okay, it is not red, not black. Black dustbin is not a part of biomedical waste dustbin. It is only white, red, blue, and yellow. So in the red, all the infectious waste, which is plastic, that will go in red. All the infectious waste, which is non-plastic, will go in yellow. All the sharp waste, metallic sharp waste, it will go in white. And all the shishe wala sharp waste, that is glassware sharp waste, that will go in blue. Then standard precautions are to be taken in not only hepatitis B or hepatitis kisi ek ne answer kiya for hepatitis B and HIV. No, standard precautions are to be followed for all the patients irrespective of their HIV, HBV or HCV status. Then a healthcare worker had an antibody titer of 100 milli international units in 2015. Recently, he had a needle prick injury from an HPV positive patient. What should be done? So again, ma'am already has discussed this very nicely in her presentation, that once any healthcare worker, he or she has achieved a titer of 10 milli international units per ml, once एक बार check कर लिया कि 10 से ऊपर है, then it is like he or she is protected for life. The titer may go down with time, but whenever there is exposure, there will be secondary immune response and the titer will go up. So there's no need to again recheck the titer. And if your titer is more than 10, once, then there's no need of getting a shot of vaccine or no need of immunoglobulin. कुछ भी करने की जरूरत नहीं है. So the correct answer here is nothing is required. Once the titer has reached 10 international units, then nothing is required even after exposure. Which of the following should be considered as infectious body fluid? It is amniotic fluid. It is not saliva, not urine, not feces. We discussed the high risk fluids. It is semen, vaginal fluid, amniotic fluid, CSF, peritoneal fluid. These are the high risk fluids. Okay, semen, saliva, urine, feces, sweat, tears. These are the not risk fluids. They are not at risk fluids. So I think now I have answered the queries. Can we see the difference between the pre and post workshop?
Hello. Hello, ma'am. Yes, ma'am. Can I stop the sharing?
Oh, I think you have already stopped it.
No, ma'am. It's showing.
Acha. Can you just display the difference between the pre and post? I've again and again requested for that. There is one more query. When you say soap and water, we basically want to clean that area. So we can use hand wash too. Yes, you can use hand wash. Or is it something different because of the detergent-like constituents of the hand wash? No, you can use any non-medicated soap, any hand wash. No disinfectant, no antiseptic. Simple plain hand wash or soap that can be used.
Ma'am, actually, now I can't show you the results because the poll results is creating in some times after. So now it's not possible, ma'am.
So you can just share it with the organizers, Dr. Lakhan and Shruti.
Yes, ma'am. Sure. I will later share the result. Sure, ma'am.
Okay. Okay. So thank you so much, all the participants, for your patience. And I hope you enjoyed Dr. Ekta's session. She is a stalwart in the field of HIV, this hepatitis B and hepatitis C. And thank you, Shruti and Amrita and Lakhan. And thank you, Haris sir, if you are here. You were there throughout the session. It was a motivation for us. Thank you.
Thank you so much, ma'am, for being with us. It was such a good session. Thank you so much, ma'am.
Smile बहुत प्यारी है तुम्हारी.
I would request all of
दोनों की.
So I would like to request all of the participants to please fill up the feedback form, and you will be getting the participation certificate there only itself. And I would request Amrita to please come for the vote of thanks.
Thank you so much, Shruti. I deem it great honor to propose vote of thanks on behalf of IMA-MSN UP, HISI, and SNO-India National, and all those who have been making this workshop a resounding success. First of all, I would like to express my gratitude to Professor Haris sir, Dr. Ekta ma'am, and Dr. Fatima ma'am, and also my heartiest gratitude to our organizers, Sakshi and Lakhan, for organizing such a wonderful and informative session. I extend my gratitude to my co-moderators for smooth conductance of this session and all the people who participated. Once again, thank you everyone for your cordial cooperation. Looking forward to more such sessions and active participation. Thank you so much.
Thank you. Shall we leave now?
Yes, ma'am.
Thank you.
Thank you.
Amrita, post the feedback form again in the chat box. People are asking. Okay.
Okay.
Yeah. Okay, Shruti. And yeah. Also, I would like to coordinate to wait for 1 or 2 minutes so that people participant can fill up their feedback form.
So the link has been posted in the chat box. All the participants are requested to, just fill this up.
Thank you, Cleaner, for providing this platform. And I request all the participants to leave the meeting as the workshop has ended. And feedback form link we have circulated in the chat box.